Hello once again, and I'd like to say welcome and thanks to everyone for attending. My name is Dr. Belinda Nelson. I'm with the University of Michigan Center for Managing Chronic Disease, and I will be the moderator for today's webinar entitled Community Health Workers and Reducing Disparities in Diabetes, Lessons Learned from the Front Lines of Care. Today, you will learn more about the role of community health workers and how the Diabetes Equity Project located at Baylor, a part of the Alliance to Reduce Disparities in Diabetes, which is a national program funded by the Merck Foundation, is currently using community health workers to improve care coordination and seeing improved health and reductions in disparities as a result. First, you will hear from Christine Sneed, the Director of the Community Care Coordination Program at Baylor Health Care System. Ms. Sneed will talk more about why Baylor instituted the community health worker role and the steps taken to recruit, train, and to credential the community health workers. Next, Magdalena Lopez, a community health worker at Baylor, will tell us about her typical day and share stories about how she's helping patients to improve their health. Afterwards, Dr. Jim Walton, former Vice President of Network Performance at the Baylor Quality Alliance and now President and CEO at Genesis Physicians, will outline a path for greater use of community health workers to help improve care coordination and reduce disparities in diabetes. Dr. Walton will discuss policy considerations that could enable successful integration of these trained professionals into the health system. After the panelists have completed their discussion, we will have about 15 minutes for a brief Q&A session. We will take questions following Dr. Walton's remarks. And to ask a question of the panel, you will type your question into the chat box that you find at the bottom right of your screen under the header, and then hit enter. This will send your question to me and the panelists. Now, if your question isn't answered today during our broadcast, we will respond to you via email starting later this week. Given the amount of time that we have at this point, we are ready to turn things over to Christine Sneed, who will begin today's discussion. Hi, Christine.
The scope of the problem here in Texas, our demographics are such that the Hispanic population is growing, and by 2040 we anticipate it to grow substantially. This is reflected in our own clinic population, which is where we've embarked on this community health worker program. So the next couple of slides, I'll show you the demographics of our program, which really mirror our charitable clinic population. As you'll see, the ethnicity is about 50%, a little over 50% Hispanic, another 25% African American, and the primary language spoken is Spanish in about 60% of our patients. The age population that we're working with is primarily adult, between 19 and then sort of pre-Medicare age, and the educational level is about 3/4 of high school education and below. So our problem was, and as I mentioned, we have the program embedded in 5 community clinics that are focused on charitable care for the uninsured low-income population. And our problem was that there were no diabetes education services available. There was a clear gap. The certified diabetes educators that are within the system bill for their services, and so really we're focused on the insured population. Additionally, with the population that we served being low income and having many social and financial barriers, a traditional diabetes education type of program, group classes, doesn't necessarily address those types of barriers to self-management. So in our population, we had a number of health literacy barriers, financial, language, and just sort of some general mistrust of the health system. So one solution that was considered a number of years ago in one of our clinics was, what about a community health worker? Could a community health worker do this type of role effectively within our population? We're fortunate to be in the state of Texas, where we've had certified community health worker programs since 1999. So we had that context within which to work. But certainly this idea of a trusted peer that could help patients navigate not only medical services but social and provide culturally appropriate health education and information had some appeal for us. As well, it is a lower cost intervention, and particularly when we're dealing with basically all uninsured population, having low cost for sustainability was very important to us. So to give a little background for this story, this intervention was embarked on at one site, which actually Magdalena Lopez works at, one clinic site, and they, through the work of Dr. Walton and an endocrinologist, developed a protocol around this and found that after 1 year of being up and running, there was some statistically significant improvement in A1C between patients that had this intervention and those that did not. So our question became, could we scale this more broadly than the one site? Hence, we started working with the Alliance. So we're very grateful to the Merck Foundation for funding this project. It's a 5-year project. And to the Alliance National Program Office, as well as the other partners, as we've learned from them over these past 4 years or so. And so our idea was to roll this out to an additional 4 sites. So to get to the tangibles, initially we obviously had to do recruitment of community health workers. We had to create a job code within Baylor Health Care System to do that recruitment, because they all are Baylor Health Care System employees. So the requirements included having a high school diploma, being fluent in Spanish, because our population was heavily Spanish speaking. We did prefer to get existing medical assistance only because this protocol involved some blood pressure measurement, point of care A1C testing, point of care glucose testing. However, not all of the community health workers that I hired are medical assistants. And then we recruited via the charitable clinic network that we had established to see if they had existing staff or volunteers that would be interested in this role, certainly via our own website, and then a local workforce development site. Magdalena and I both interviewed candidates and conducted behavioral interviews and really looked for certain behavioral traits, compassion, communication, being self-motivated, and a very strong team player. As well, it happened that quite a number of our candidates had had some personal experiences with diabetes with family members, and I think that helped to create passion in them around helping this population. From a training perspective, as I mentioned, we're very fortunate in that Texas adopted a formal certification about 15 years ago, and it's a pretty comprehensive program. It's a skills-based program of 160 hours, and then once certified, community health workers have continuing education requirements similar to other disciplines of about 20 hours every 2 years. The competencies that are taught in this skills-based program are around communication, service coordination, capacity building, advocacy, organizational skills, and a little bit around chronic disease. So as we rolled out the training, we felt that it would be, the community health worker training was very heavy on general skills, but it also would need to be augmented with some disease-specific training. I did list for you a couple of websites you might take a look at if you're interested in community health worker, what the curriculum looks like. On the state of Texas's site, there are a couple of web-based programs that are run by training agents, facilities here in Texas. As well, I think there's some interest now from universities and other types of entities for community health workers. I was recently at a population health colloquium where Temple University presented on a curriculum that they've just developed for community health workers as well. So around the role, we had some additional training to this generalized community health worker training. And there are a couple of good resources that I found were helpful. One is the American Association of Diabetes Educators now has a level 1 certification for basically for peer type of diabetes educators. It's a web-based program. It's 8 to 10 hours and consists of 6 modules or so, which are pretty comprehensive. We also locally here used our own patient education practices that were led by certified diabetes educators, so all the community health workers went through those, which just reinforced the diabetes material, but also gave them a sense before beginning their jobs of what patients ask, what's the real life kinds of questions that are coming up from patients around diabetes. We did implement a pre-test and post-test for the community health workers, so we knew they were prepared to go out and begin the patient education. The other thing we looked at was clinical skills competency. As I mentioned, there was some point of care A1C testing and other basic skills that needed to be verified, so we utilized, so we had a day to assure competency. Certainly discussed the protocol in detail and job scope. Went through training around the EMR, and then also took the opportunity during the initial training for the folks to shadow the healthcare team members within the clinic, just to give the context of how this work was going to be embedded into the clinic from a workflow and just a general knowledge perspective. Ongoing, we felt that training is really important, and to keep that going, not just make it initial training. So we average about 15 to 20 hours a year of continuing ed that's related to diabetes, its comorbidities, motivational interviewing skills, and compassion fatigue, which really is something that the community health workers themselves brought up. And so we brought in a primary care provider to really speak to that with the group. The other thing that we've developed are competency assessments around the patient interaction itself. So a supervisor will sit down quarterly with each of the community health workers and shadow a patient visit and do some assessments around community health worker competencies. This next slide is very, very busy. This is our protocol in great detail and difficult to read, but what I wanted to convey was this idea of having a very defined protocol which increases the comfort level, I think, for the community health worker as well as the rest of the staff that are interacting with the community health worker, that this is what you can expect will be reviewed with patients, this is the job scope. And I think that's, and then there's much more detail behind that that we include in training, but it gives you a sense. There's another program that I have managed around community care navigation, which is really utilizing a community health worker to navigate low-income, similar types of patients who don't have insurance, who've been hospitalized and don't have any primary care to primary care. And that's been fairly successful, and we've used, as far as community health worker certification, that same type of training, and then had additional role-specific training for this role. So what do I think helped make this program work so far? First of all, that we have had an evidence-based pilot with which to base our work. We have had the luxury of having a standardized certification here in Texas and have been able to utilize that. And then we've created more standardized training around the diabetes piece of it. Also, because this was multi-site, it was important for us to have centralized program management. I think it would be very easy if the community health workers were embedded in various primary care clinics for them to get, and reporting directly to the clinic manager for their work to sometimes take a back seat to pressing sort of clinic standard operations, front desk work if someone's sick, that type of thing. And by having a centralized program manager, it assures both the quality of the program and then the focus of the program. Lessons learned really were, number one, we saw a big benefit with the community health worker patient relationship, and providers began to acknowledge that. The community health worker, because of the knowledge of the cultural and other barriers and the fact that patients don't perceive a psychological height with a community health worker like they may with a physician or even a nurse, that the community health worker, if they have direct access to the provider, is able to inform medical management from a different angle than typically happens in a primary care team. Certainly, having CHW competency is definitely a must-have. I mean, there needs to be, I think, good structure and around the protocols, around the training, and assuring the quality of the program. We talked about the EMR access. About halfway through the project, the community health workers were able to chart in the EMR, and this just improved that relationship with the provider that much more. The last bullet point about relationships, this was a new program, and I think it really takes very strong relationships with stakeholders to make it happen. This is a new role for the system, and so a little bit of hand-holding is required, and inevitably there are bumps in the road, and the relationships help you get through those. From a big picture perspective, with Baylor Health Care System, we started with one community health worker in 2005 via the CODE program, and we're growing slowly, but we are growing in a positive direction for community health workers. This year, we will have 32 community health workers within the system in 5 different programs. And the community health worker team for this project, thank you very much. I thank them for their great work with our patients. And that concludes my comments, Belinda.
Thank you so much, Chris, for your presentation. It's very clear that your team there has been quite successful in moving forward this role. And at this time, we're going to hear from a community health worker who's on the front line of care delivery there in the community. And I'd like to turn it over to Ms. Magdalena Lopez.
Hello, everyone. My name is Magdalena Lopez, and I work at the City Square Clinic. And I'm going to start by describing my role as a community health worker. Part of my role is to build trust with patients. If I really want to help a patient, I need to know what's going on in their lives that is keeping them from reaching their goals. So this is really important. Also, I connect patients to resources such as local food pantries, and I educate patients about diabetes and making changes in their lifestyles. At every visit, I help patients set a goal, and this is a goal that they're going to be able to achieve. We don't want to set patients for failure, so we ask patients' input in setting a goal. I also help patients to communicate with providers, and this can be through the EMR or in person. And I let patients know about their medical treatment when the providers ask me to do that. Next, I'm going to describe my workflow. A typical day for me is about 8 patient visits, and they're one-on-one. I also make about 4 telephone calls. And these are calls that providers have asked me to call patients with medication changes, or those patients that were recently started on insulin. They asked me to call them and see how they're doing, if they have any questions. Also, my communication with the primary care provider is mainly through the diabetes pathway. This is an EMR. Also, if I have an urgent situation, let's say I might have 3 in a day, I can go and talk to the provider in person. And one of those situations might be like a foot ulcer or blood glucose higher than 250. That's when I need to go and talk to the provider in person. Also, we have the team meetings. The community health workers, we have 2 meetings in a month. One of them is a conference call, and the other one is a face-to-face meeting. There's also a monthly meeting with the clinical staff and the community health workers, and another meeting with the project manager, clinic manager, and community health workers. Now I'm going to describe a typical visit for a patient with a community health worker. The first part of it is getting the clinical measures. At every visit, patients bring the glucometer, and I upload the readings so that providers can see them. I also check weight, blood pressure, glucose, and an A1C if needed. Every time they come in, I need to be checking their feet every time they come in. I also do a depression screen. This is usually at the third visit, but there's some times where patients show signs of depression, so we do it sooner than that. And any red flags are communicated to their provider. Okay, the second part of the visit is the education part, and we focus on self-management training. We also talk about the AADE 7 behaviors such as healthy eating, being active, monitoring, taking medications, problem solving, reducing risk, and healthy coping. We also identify their barriers, what's keeping this patient from reaching their goals, and some of them might be financial. If we found out that's because they're not taking the medicine, they're not able to afford vegetables, then we can refer some of those concerns to the social worker that is in the clinic. Okay. I also schedule their next follow-up appointment, which is every 3 months, and encourage them to call. If they have any questions, they're notified, they're encouraged to call us. They don't need to wait until they have an appointment with us. Okay, next we have the responsibilities for the CHWs and the PCP and the patient. And I'm going to call some of them. So some of the responsibilities for the community health worker, as you can see, is educating patients about diabetes, finding out what's keeping patients from reaching their goals, scheduling follow-up appointments, and getting the clinical measures. Now, on the patient side, it is important to know that patients have input. They need to have input in their medical treatment because they're the ones that are going to go home and decide to take their medicines or decide to exercise. So they have a huge part in this plan. And then the PCP responsibilities is trusting us, trusting the community health worker, and showing us their support, being available for when we have questions. That's really important for the patient. Next, I'm going to talk a little bit about the communication with the providers. If there's something urgent in the clinic, as I mentioned before, such as a foot ulcer, we need to go and talk to the provider in person. This is something that needs to be taken action, that something needs to be done about it. And for non-urgent situations, we can do that in the EMR, such as the patient needed a medication refill. We can do that through a phone note in the EMR. All the visits are documented in the EMR. And to your right, you can see a screenshot of it. And this is called the diabetes pathway, and that's where we document if patient is compliant with medicines, if they're following a diet, exercise, if they're monitoring, if they need to be taking an aspirin, are they taking it? That's where we document all of that. And then a report is shared with the provider quarterly, and that has the A1C average for the patients that we've been seeing. Next, I'm going to share with you some quotes from the providers, and this facilitated, they are saying what facilitated the acceptance of a community health worker in the clinical environment. I'm not going to read all of them. I just want to read the first one, and it says, when the CHW was offside, it was low value to me because I didn't know what was going on or who she was. When she moved on site, all of a sudden, she was part of the team. We are discussing patients together when red flags happen. I think this is really important, and this is even easier for the patient because if there's something urgent going on, immediate action can be taken by speaking to the providers. They can even be seen by the provider if there's something urgent going on. Next, I have some feedback from the patients, and what they like about it is that they feel safe when they're with us. And I think that's why, because the classes are one-on-one, and that makes it easier. They feel more comfortable about asking questions. They're more open when they're not in a big group. Okay, and for this, I want to read the last quote. She tells me the truth. I believe she's honest about things. I feel I can get open with her because she's the kind of person who will listen to what you're going to say. And I like this quote because it relates to the first part of my presentation. When I was talking about building trust with a patient, this is coming from a patient that trusts his community health worker. Now we have some quotes from community health workers. And I would like to focus on the second one, where it says they are moral support. We vent and help each other out. They're like a support group. Yes, this is really important too, because we also need help, and it makes it easier when we talk to other people that are doing the same things. They can help us out because they might have already experienced the situation, one of the situations we're going through, and it makes it easier for us too. Okay, next we have some tips for making the community health worker part of the clinic, of the healthcare team. And one that we like a lot is scheduling the appointments the same day with the community health worker and the provider. The appointment with the community health worker is scheduled prior they see the provider, and this is really helpful for the three of us, the patient, provider, and CHW. Why? And that's because we get the information, we get about the barriers from the patient, what's keeping patients from taking the medicine, from exercising. We also check the vital signs, and like I said before, we also do an A1C if needed. That way, by the time they go and see the doctor can see that information in the EMR prior to seeing them. And also, like I said, if there's any red flags, we can talk to the doctor even before they get to the patient, even before they see the patient. Okay? And we're frequently communicating with providers, with the clinic manager, program manager. We can go to the program manager anytime that we have a question, that we need help, we can go and talk to her. Also, at the team meetings that we have, we learn from each other. It's really helpful. And finally, here is my information, my email. If you have any questions, please send me an email. And also, we have my manager's information. Thank you.
Thank you so much, Magdalena. That was a very rich description of your day-to-day life as a community health worker, and I think that everyone will find that very informative. At this time, I would like to introduce you again to Dr. James Walton. He's the President and CEO of the Genesis Physicians Group, and he's going to provide us with a presentation on policy opportunities to integrate community health workers into more health care settings. Thank you, Dr. Walton.
So basically, as you've heard, the goal of the Diabetes Equity Project in Dallas was to optimize primary care for at-risk diabetic patients, trying to achieve the Institute of Medicine's triple aim. And I think there's two key points that you've heard Chris and Magdalena talk about. One is that we optimize the primary care, and the verb optimize really speaks to this idea of primary care physicians' time pressures to really address some of the critical issues that at-risk diabetics face. So what I think Magdalena was pointing out was that what makes people at risk sometimes relates to the non-clinical issues that patients and people confront on a day-to-day basis that a community health worker is strategically positioned to help. So we kind of move out of the clinical space per se relative to diabetes and work on the social issues, which are a lot about trust and the idea that people are disenfranchised or marginalized, and it's very difficult for a physician in the limited amount of time that they have to kind of engage those patients in a meaningful way. So our tactics were to embed the community health workers within patient-centered medical homes, to train them beyond the stage where we met them, and we created this term called diabetes health promoters, created a formal job position within the Baylor Health Care System. And then third, and very importantly, we created a dedicated software system for them to capture their data and to facilitate communication back to the physician. We adapted an existing program, which we call CODE, or Community Diabetes Education Program, that Chris talked about, that had been trademarked and developed in 2005, and had had some research done around it to show that it was effective. And then finally, and certainly not the least, is that we connected the project to a large community health network that had been developed in the Dallas County area to help connect people with complications or complexities of diabetes. So we weren't just leaving community health workers with just counseling or advising patients, that we really could do something with their patients to help them with the clinical issues that were so difficult to deal with at times. The improvement in disease control is the next slide, where we have experienced significant growth across 5 different locations. Up to over 1,200 diabetic patients are getting care now. As Chris indicated, 89% are racial ethnic minorities, and what you can see in this data is the good control where the patients started. Around 32% of the patients came in with an A1C less than 7, and we've moved that up into right around 50%. And the patients who were in poor control, 38% of our patients came in with an A1C greater than 9, and they improved to around, we got that down to around 17% over 12 to 24 months. And that's been holding longer than that period of time. And you can see the average A1C at initiation of 8.4, and that's now at 24 months around 7.2. So we do see that there's significant evidence that the disease seems to come under better control. And of course, lots of people will ask, well, what really happened? Did the patients become more adherent? Did they lose weight? Did they start eating better? Did they start exercising? So people want to know the magic sauce of how you move this. I think Magdalena really brings it out, that the trust increases and the satisfaction and the sense of patient engagement increases. And I think that that's really the holy grail here, is that patient engagement happens. And for each patient, it's something different. In some cases, it's diet. Some cases it's exercise, sometimes it's medication adherence. And so what we think, these are just proxy indicators that we've built a relationship with the patient, and they then know better, and they start executing at a better level. What I show you here is then this, the other downstream impact is once the patients seem to get some better engagement with the physician and the team, we see also, at least within the Baylor hospitals, that the patients actually stop or reduce their visitation rates to the ER, as well as spending time in the hospital at statistically significant levels. And so that also translates into some cost savings per patient as you move through putting this project into place. And certainly not least is that we show that patients increase their satisfaction. Now, our patients have some language and English reading capability. They have some limitations in how to do a formal survey, as you might consider with Press Ganey, a mailed survey or call survey. So what we did, we had a point of service survey that allowed patients to give us immediate feedback after the visit. That enabled us to make adjustments in the way we manage the staff, as well as solve problems with regard to our operations. And so we feel like this is a good proxy for satisfaction, given our limitations on formal satisfaction surveys. So the 3 lessons that I would say that we learned in Dallas is that that we have professional development of community health workers, and that the systems need to commit to transforming the primary care physician care team. That if we really want to talk about team-based care, then primary care physicians need help, and that means another team member. That, of course, sounds anathema to the people who want to make sure that the PCP offices stay lean. However, what we've been able to demonstrate, I think, is that for both quality improvement, patient satisfaction, and cost, we think that we can prove that adding that care team member inside the PCP actually translates into a cost savings or a cost benefit for the entire system. The second lesson is this dedicated care coordination, that your traditional clinical EMR is not really adequate for the kind of services that are needed for this work. And we need to be more focused at a community health worker level at optimizing communication across the team by sharing information around behavior, social, as well as clinical data, and then reporting outcomes on a reliable basis. And then third, and certainly not the least, is the good work that Magdalena and Chris have done in this work around managing productivity, quality, and satisfaction of the actual team. And so it's not adequate just to take an individual community health worker and embed them as a solo actor within a primary care team, because primary care physicians and practices really don't have an experience with how to manage them or what motivates them. So we kind of held a centralized training program and ongoing relationship with the team. So that, and we've used the nursing discipline for that, because we believe that that's really a deeply held value for the nursing profession, and it seems to have worked out really, really well. So centralized training, centralized recruitment, team building, and troubleshooting has seemed to really be one of the key pieces of our work together. So I'm going to leave it to the questions, because I know this is a rich dialogue, and Chris and Magdalena really have a lot of information they'd like to share with you.
Thank you, Dr. Walton. I'm sorry, I was muted there for a moment. That was a very rich and informative discussion. And at this time, we do have about 15 minutes that we're going to devote to our question and answer session. We are currently organizing the questions, but to begin, I have a question that I think would be appropriate for either Chris or for you, Jim, and that is, how receptive were the Texas officials you work with to this idea of establishing the community health worker credentials? For example, what information or what data did you need to convince them of the value of establishing community health workers in the health system?
Chris, I'll just speak to, when we started in 2004 talking about the use of community health workers, there was already activity on the border of Texas with the type of worker called health promoter or promotora. So in some sense, Texas has benefited from a lot of really meaningful work along the border around how to improve a lot of clinical healthcare issues using health promoters. So we inherited in our work that fine work that has been published, and I think you can find that in the literature. That being said, then we made sure our program focused on the idea that the state of Texas had already approved a certain type of training for the community health worker discipline, and we wanted to make sure that our staff met that minimum requirement after we hired them. So when we started back in 2005 or so, there really weren't a lot of folk trained as community health workers in the state, and if they were along the border. But since then, and I'll let Chris pick it up from here, since then that's really kind of taken off. So go ahead, Chris.
Yeah, right now there's about 2,000 community health workers in the state of Texas. So, but to Jim's point, we were fortunate in that already was available to us, that training. It was already, there are certain locations that are certified as training sites for community health workers. Locally here, we use the University of North Texas. So it's between universities and area health education centers. Those are typically the training sites. So we were fortunate to just build off what was already in place.
Thank you, Chris. I do have another question for you, and it's related to the career path. 1 second here. In general, can you give us a description or some idea of how you developed the career path, what it entails for the community health workers?
Yeah, so we embarked on this diabetes work, and then I had one slide on the community care navigation program that utilizes community health workers. And what we found is because of that program in particular, there was exposure to the social work care coordination department for the system. And their corporate director wanted to institute a community health worker driven intervention for another purpose. So this provided the opportunity for me to work with that corporate director to say, you know, maybe it makes sense that rather than just have a specialized like diabetes health promoter position and a different specialized community health worker position for a different program, we create a community health worker job code for the system, similar to how you would do with a registered nurse or, patient service tech. And so that's what we did. And the thought being that that job code could be utilized for various programs. Now it's still baby steps. But at this point we have 30-some community health workers, or will in the next couple months, in a very large health system. But at least we were trying to set the stage for sustainability and for future development of community health workers. So at that point, we created a Community Health Worker 1 job code. Subsequent to that, we created a Community Health Worker 2 position. So I've been able to promote a couple of community health workers to that role where they serve in more of a lead role. And the next step would be to move to a supervisory position.
Thanks so much. I do have a question here from Magdalena, and it's about the caseload. Can you give us a sense of what each of the community health workers' caseload is, and also what do you think is an ideal ratio of patients per community health worker?
Okay, so right now 250 is the number, 250 patients per community health worker, and that's about okay, because if we get too many patients, then we're not going to be really efficient, like able to manage a lot of patients. But 250, that's what we have now, and that's manageable.
Okay. Sounds like a lot. In addition to that, Magdalena, let me ask you a question that has been commonly posed to me during discussions about the role of the community health worker, and that is building the relationship and the trust with the healthcare providers at the clinic site. Can you give us a little sense of what that's been like for you?
Yes, it's like, well, first of all, as the community health worker, we're trying to communicate with patients, and then we talk to the providers about what's going on with this particular patient. And then provider, for example, if we have an emergency situation, we can go and talk to the provider, and then the provider can see the patient the same day. And that helps the patient.
And Belinda, if I could add on to that a little bit, I think that it doesn't happen overnight. It has to get built. And Magdalena's been at her clinic for a long time, so she has a very high level of trust with her providers. But a couple of things I think help. One is to be able to report on outcomes, and that's something we did intentionally, like every quarter. Here's the latest outcomes in regards to A1C or blood pressure control for the patients that are being managed. Also, when new providers are hired, and we had to kind of build to this, but when new providers are hired, then they meet with me to learn about the program and also sit in on a patient visit with a community health worker and the patient. And many times they don't necessarily have the perspective of what happens during that visit, and that begins to make it concrete. I think that helps. And then lastly, I think it's patient feedback as well. So a patient coming in to see the doctor who says, oh, Magdalena, I didn't understand really how to, the diet part of this, but then Magdalena explained it to me and I got it. So it's just kind of getting that feedback from providers, or from patients, but it definitely takes time to build.
Thanks, Chris. This question has been, in part, I think, answered to some extent by Jim, but if you want to add to this, the question reads, have you been able to quantify the cost savings that community health workers help your organization realize?
Yeah, this is Jim again. I've been having this conversation quite a bit, both while I was at Baylor and since I left, and kind of give you another way of looking at this. In my new role as providing leadership to a large independent physician association that's moving into accountable care, what we kind of sensed before, and we know now for sure, is that physician practices in individual physicians as well as small groups and large groups are going to be financially rewarded for achieving the higher degrees of quality, higher degrees of patient satisfaction, and cost control. And so on all three measures, I think the evidence is that the community health worker strategy that we employed inside the chronic disease of diabetes indicates that the community health worker model can achieve all three of these triple aim items. So it is a combination of both top-line reward opportunities by achieving greater quality measures and satisfaction measures for patients, as well as expense reduction by avoided hospitalization or shortened hospitalization and less ED visits. And so I think you could take the data that we've got in this slide deck around what we've experienced here in Dallas with our one hospital and generalize that to populations that you might care for if you kind of hold the caveats. And there's several caveats. One is our population is a very significantly minority, Spanish-speaking, low-income, low-health literacy population that doesn't have a lot of insurance. And so I would just kind of cast everything in that light, but I would say that I've reviewed the literature, and we continue to see that this evidence shows up over and over again, no matter what population you work with. So that's my answer, Belinda.
Okay, thanks so much. This next question, I think, is probably one that I'll ask you, Chris, and perhaps Magdalena. Do you have certified diabetes educators in the Baylor system, and how have they responded to and worked with the community health worker role at Baylor and in the practice sites?
Yes, we do have CDEs in the system, and I would say that's been a journey. I think in the beginning sometimes there can be some sort of natural turf issues that can happen. It didn't happen with all CDEs, but there can be a little bit of that. And I'll give you an example. One of our sites actually had some volunteer CDEs there managing patients prior to the community health worker coming in. And so once Martha started at this site, there was a little bit of angst around who was going to do what. And what we needed to do in conjunction with the medical director of the clinic and the executive director of the clinic is really to establish roles. And I think once that's clarified, then you can move forward pretty effectively. So the certified diabetes educators at the site really dealt more at their at their top level and doing insulin adjustments and doing more things that require a CDE. whereas basic lifestyle education was taken over by the community health worker. And so that worked well, but initially there was some, push and pull to get to that point. I think at this point, when I talked with, because I work closely with the system director of community diabetes education, and I think there's much more openness now than maybe 4 or 5 years ago, because I think there is a realization that CDEs can't, there's so much demand and so many patients with diabetes, and it just can't be covered only by CVEs. So I think now there's more of an acceptance of the community health worker as kind of an extension of the CVE and doing lower level, non-medical, obviously, work with patients.
Thanks. That provides a nice little segue into the next question. How do you go about selecting the healthcare providers that would actually receive a community health worker? Do they have to apply to have a community health worker at their site?
Jim, do you want to speak to those?
Yeah, I'll tell you how we started. So we identified, community clinics or community providers who had been working in the space around diabetes and chronic disease for at-risk, vulnerable populations for a number of years, and asked them if they would like to become more expertise in that area, rather than having to refer their patients to or out, if you will, to a diabetes program. Would they like to have that on site? So that's the approach that we took. We did the outreach. I think both models, there's going to be another model out there where there's going to be physicians who hear our practices or clinics who hear about these types of models, who are going to be asking for the service as they want to improve their quality or satisfaction or cost performance within their organization. So I think it's going to be both types of methods, but we, in this particular project with Merck, we really looked for those people who were already in motion around this type of problem.
Thanks so much. At this time, we do have some other questions, but we just have a few minutes to wrap up, so I just want to take this time to say thanks to everyone who sent in questions. And as I mentioned earlier, we stored the questions that we couldn't answer today, but we definitely will be in touch with you with responses very soon. I hope that you found today's discussion to be informative, and that hopefully you'll be able to incorporate some of the tips about the community health worker role into your own work. Thanks again to Chris, to Magdalena, and Jim for your presentations. They were very informative, very rich, and I think provided a lot of practical information for people who are interested in advancing the community health worker role in their work. Also, I'd like to say thanks and make a special thanks to the Merck Foundation for its continued support of the Alliance to Reduce Disparities in Diabetes. Lastly, the archive of today's webinar will be available soon on our website in the next few weeks. So you can please direct your colleagues, those who weren't able to join us today, to view the webinar on the Alliance website. Now you can also connect with us on Facebook and on Twitter. So that's going to end our webinar for today. I want to thank you so much. I've enjoyed listening to the presenters. And again, I hope that you found this to be helpful to you. Thank you.